Hello and welcome to #OurDocTalk. This is NorthBay Healthcare's effort to reach out and connect with physicians in the community and talk about important health issues. I'm social media specialist Robin Miller, and with me today is Dr. Brian Vikstrom. He's one of the oncologists and hematologists with the NorthBay Cancer Center. Dr. Vikstrom earned his medical degree at Columbia University College of Physicians and Surgeons in New York. He is board certified in medical oncology, internal medicine, and hematology, and has been with NorthBay since 2005. Welcome and thank you for taking time out of your busy schedule to do this and chat with us today.
Oh, I'm happy to be here.
Just a word before we get started to those who are tuning in on Facebook to watch this. You can ask questions during this chat and we'll pass that along to the doctor. All we ask is that you try to protect your personal health information. To post a question, you click on the comment button just like any other Facebook post and type it in, but we're asking you not to use first person. Don't say, I have this, or I experienced this. Instead, ask it in third person. What if a person has this, or what is your thoughts on this type of treatment, and that sort of thing. So we want to protect your health information. All right, so let's get started. We're going to start with the basics.
Okay.
What is prostate cancer and how is it diagnosed?
Well, prostate cancer is a cell growth problem where you will have cancer cells growing in the prostate. If you take a look at a biopsy, which is you put a needle into the prostate, you take the tissue out and you look it under the microscope, you will see the normal prostate cells, but you will also see cells that look like prostate cells, but there's like a characteristic difference between them and the normal cells. The parts of the cells will look more abnormal, like the nucleus. You will have cells growing a lot faster than you would see in the normal tissue. You will see things called mitoses, okay, which are it's like the appearance of the cells when they're about to divide into two. And so, really, cancers in general are problems that have to do with cell growth. Your body normally will make new skin cells, mouth cells, blood cells, all types of cells, because you need continual replacement of the cells that are in the process of getting old and are no longer functional. One of the problems we have with cancers is when that cell growth regulation gets disruptive and then it starts growing. One of the problems cancer cells have is many of them will also develop the ability to spread to other parts of your body. Most cells stay put, they stay in place, but cancer cells can develop that ability to go, say, to your liver or to your lung. In the case of prostate cancer, the most common place for it to go is to the lymph nodes and to the bone.
And so we had one question posted in advance of this chat. It's actually two questions in one. At what age should men start to get screened for this? And then after that, how often do they need to be rechecked?
Well, that's actually a very complicated question.
Okay, good.
In fact, you can go to different professional societies and get different answers. Screening for prostate cancer has been very complicated. And what makes it tough is you can diagnose a cancer, but that doesn't mean that cancer is going to kill you or do anything. In fact, there are many people who have prostate cancers, and if you leave these people alone and don't do anything about it, they could live for decades and not have any problem. In fact, they've had autopsy series on men in their 50s who died from other causes, heart attacks, car accidents, strokes, whatnot, and they found that up to 30% of them had prostate cancer and did not know it. Now, if this were really a problem for every single man that had prostate cancer, you would expect us to be dying like flies. And in fact, in men in their 70s, they've had autopsy series where up to 70% of men have prostate cancer. This is one reason why sometimes we've developed techniques of, a strategy of trying to determine if we can find out which cancers are the bad actors that need to be treated and which ones can be observed. For men with what we call good prognostic signs, so They're not having any symptoms from the prostate cancer. You can't feel it on examination. Their PSA is below a certain point. And there's also something called a Gleason score, which is kind of what we call how ugly the cancer cells are. That can be used to determine if you need treatment. Now, it should be stated that if you find a cancer and you decide to go for treatment, treatment can affect your life significantly. Men can develop problems with impotence. They can also have trouble with urine leaking. And so, you know, figuring out if cancer needs to be treated is very important, because it is possible that if you go for a curative treatment, we can cause significant health problems that will affect you for the rest of your life, and it might be for something that wouldn't kill you in the end. Now, we typically recommend starting screening for prostate cancer at the age of 50. This is something that is not an absolute must. This is something that all professional societies say should be discussed with patients. If you do get tested and you find out your PSA is normal, this is a blood test, then you can get rechecked every 2 years. Now, there are certain groups of men who are at a higher risk of developing breast cancer, and this depends on your family history, whether or not you carry, say, a cancer gene called BRCA. African American men are also at a higher risk, and for people in these groups, we can even consider starting screening at the age of 40.
I was going to ask you the question later on, but I'll ask it since you
Sure.
brought it up about studies that have shown as many as half of men over 60 have prostate cancer, but it'll never develop into the aggressive. So how important is it to treat, and how do you know when enough is that it needs to be treated?
That is a very tough question. There are a lot of researchers working on that right now. So again, what we tend to look at are risk factors. So if you have a PSA over 10, that's a little bit of a higher risk. If you have something called a Gleason score of 7 or higher, or if you have a mass on your prostate that we can feel, these are in general felt to be higher risk features that require some form of treatment.
Okay. And can you explain what is PSA?
So PSA stands for prostatic specific antigen. An antigen is just a chemical, okay? And PSA is a chemical that is made only in the prostate. And we found that it can go up when someone has prostate cancer. It can also be high in men who have enlarged prostates for other reasons. So just because your PSA is high does not mean it is a prostate cancer. Now, if you had your prostate removed, you shouldn't have any PSA,
Okay.
because it's the only organ that makes it. And so that's one reason why for men who've had surgery, we will follow the PSA. For people that go for radiation for prostate cancer, since radiation does not remove the prostate, it's very normal to have a detectable PSA, but we still monitor it. Our thresholds are different for determining if it's a problem.
And how high of a level, I mean, what's a normal level of PSA versus something that would make you want to do more testing? Yeah, I'm sorry.
Boy, you're asking all the tough questions.
That's
Robin.
what we do here on our Doc Talk.
Well, there are men who have, typically the normal range is up to 4 or 4 nanograms per milliliter, I believe. Okay, now there are men who can have a PSA of 5 or 10 who don't have the cancer. If you have an enlarged prostate, and men will get larger and larger prostates as they get older, you can have higher PSAs in those settings, but if we're doing a screening PSA and the PSA is above 4, typically we will recommend some form of biopsy. Now, if the biopsy doesn't show anything, then it's very common that we will monitor the PSA for any change and how quickly it changes. If you get a PSA that goes from, say, 4.2 one year to 4.5 the next year, that's relatively stable. If it goes from, say, 4.2 to 9, that's a faster growth rate, and that would be something that would require another biopsy down the road.
Okay. And so what are the risk factors? How does somebody know that they may be at risk for getting prostate cancer?
Well, a lot of that stuff has to be worked out. As I said, there are certain ethnic groups that have higher rates of prostate cancer, including aggressive prostate cancers, such as African Americans. We do know that if you've got a family history of prostate cancer, that increases your risk as well, particularly if you have men developing prostate cancer at a younger age, under the age of 65, say. There are certain genes you can pass down from parent to child that can put you at increased risk for prostate cancer. Some of these genes may also be associated with other cancers such as breast cancer or ovarian cancer. And in general, I would say, if you have a high rate of cancers in your family and there's any concern, you can speak with your physician about that and even get referred to a cancer genetic counselor who can determine whether or not your family history is of high enough concern to warrant testing.
And so for those who weren't able to be at June's Cancer Survivor Day, you talked about prostate cancer at that event. And you talked about developments in treatment. Mm-hmm. And so I kind of wanted to talk to you a little bit about some of the developments in treatment. And we'll just break them down by the 4 categories you had during your talk. The first is Anti-Androgen Therapy. What does that mean in English? Sorry. Big scientific words.
See, but if I use English, then it won't look so smart, will it? So, men make testosterone. Okay, testosterone has a lot of good functions to it, but testosterone can cause prostate cancer to grow. And blocking testosterone was found to actually improve a person's outlook with prostate cancer. Decades ago, I think in the 40s, they found that removing a man's testicles, and the testicles are your main source of testosterone, was associated with significant improvement in the size of the prostate cancer and actually made men live longer, sometimes years longer. Now, since then, we've developed medications to do what we did with surgery before. We have injections that can shut down testosterone production in the testes. We also have other medicines that can block testosterone from causing cancer to grow, because cancers have, we call receptors that will cause kind of like an on-off switch, a growth switch to flip on if testosterone attaches to it. Think of it like a key opening a lock. Now, some of the new therapies we've developed in we call the anti-androgen world are sort of developments on previous therapies. We've found that people who get injections to block testosterone, sooner or later their cancers will become resistant to that. And part of that has to do with testosterone production within the cancer cell itself. And one of our therapies, abiraterone or Zytiga, actually prevents this from occurring, and that has been found to be effective even when men stop responding to the shots like they did in the past.
And chemotherapy?
We use chemotherapy on anything and everything. And so we've tried it in prostate cancer as well. It took a long time before we found out it made a difference, frankly. The first drug that was approved for prostate cancer is called docetaxel. We do not give this to men who we're trying to treat for cure. We have nothing to show it increases a man's chance of cure. But if you do have a prostate cancer and it is incurable, docetaxel can make you live longer. And traditionally, we used it when the shots no longer worked, but for some men with what we call high-risk disease, they found that if we give this chemotherapy right away, I shouldn't say right away, but within the first several months of starting the injections, they on average lived about 1.5 years longer than they would have if we delayed starting it until later. So it's something that you typically would get every 3 weeks for 6 doses, and then you'll call it a day.
Are the chemotherapy drugs you use for prostate cancer, I assume there's different kinds and different than what, say, a breast cancer or something else?
Different strokes for different folks, yeah.
Okay.
And I mean, one of the tough things about chemotherapy is it's not altogether clear to us as a community why certain chemotherapy drugs will work for one cancer and not another. And so in the past, when a drug was discovered and it was found to be pretty helpful for fighting, say, breast cancer, They would end up testing it in people who had, say, prostate cancer, and we didn't have other treatment options, or colon cancer, lung cancer, what have you. And so with the chemotherapy drugs we use for prostate cancer, it was really a trial and error that determined it, and docetaxel was found to be effective. And then they ended up developing other drugs that were related to docetaxel, like a drug called cabazitaxel, and that was found to be helpful. But that was only discovered because we knew docetaxel worked, and so they looked for a similar but different medication rather than one that had a completely different effect on the cancer cell, like a drug called cisplatin has.
Okay. Immunotherapy.
Uh-huh.
What is it, and how does that work in prostate cancer?
Immunotherapy takes all forms. It's some immunotherapies use vaccines. Okay. We use immunotherapy to prevent infections. I mean, when you get your measles vaccine or your polio vaccine, that is a way to stimulate your immune system so that you will fight that infection and not develop it down the road. The immune therapy we have approved for prostate cancer is a cancer vaccine. It pretty much takes a chemical that is associated with prostate cancer. And what they do is they harvest your immune cells, and they incubate those cells with this antigen. Kind of think of it like finding a criminal. You got your bloodhound, and you've got a little cloth that you have your bloodhound sniff so it can figure out where to go. And after incubating your immune cells with this antigen, then they end up injecting it back into you over 3 different sessions, 2 weeks apart. And they found that that helped men with prostate cancer where it had spread to the bone, say, live longer. It is the benefit is somewhat modest, and they're trying to improve on it by combining it with other immune therapies. Okay, we've got treatments out that have come out within the last couple of years. We call checkpoint inhibitors, which rev up your T cells so that your T cells will attack the cancer, and a lot of that is related to the fact that your body has a way of marking your own cells saying, this is me, don't attack me. And if you don't have that marker, then you may not be you, and your immune system should just attack it. And as you know, since your cancer cells are growths and are formed from your own tissue, they will often have these same markers, and these therapies will prevent that, say, deactivation that cells have on your T cells. Uh-oh. So that your immune system can fight them. Unfortunately, for most prostate cancers, that form of immunotherapy has not been as effective. But there are some types of prostate cancer where it may be more useful, and you can always talk with your oncologist about that if the time should come.
And finally, genomic-based therapy. This is sort of the new frontier, isn't it?
It's a broad category. In fact, some genomic, how should I say this? So genes make you who you are, right? And we do know that there are genes that you can pass down from a parent to a child that can put you at increased risk for cancer. But if you take a look at cancer cells will actually develop new mutations in genes that had no problem to begin with. We call these things somatic mutations. And there's been a lot of research over the last several years where they found certain somatic mutations may be associated more with one cancer or another, and that mutation might actually cause the cancer to grow more, and they've developed antibody medications, developed other medications that can target this. And now most of the time we've developed this because just like with other chemotherapy drugs, you give the same drug to everyone, and some people will respond and some people don't. And they've developed some of these drugs that seem to be more effective in one group of people over another, and then they ended up saying, oh my, it's because of this particular gene mutation. And then the natural question is if this is useful for people with this gene mutation with lung cancer, maybe it would be helpful for, say, someone with a breast cancer who has that same mutation. and to a higher or lower degree, that's been found to be successful. And there are companies out there who actually can sequence the DNA of the cancer cell. Again, that's different from your own DNA. And there are companies out there that can detect mutations in a variety of different genes, some of which may have medications that you can use to target that. So that's very exciting, and there's more, and there are other aspects of genomic medicine I'm not going to get into right now, but it's a broad topic, and it's very, very exciting.
Maybe a future RDoc talk.
Maybe a future RDoc talk.
Okay, so what are some of the common side effects that you experience with these various types of treatment?
Well, the one side effect that is most significant is what I would call male menopause. So most
Didn't
men,
know that existed.
most men don't have the, I shouldn't say the joy of going through menopause, because even though testosterone levels can decrease over time, it doesn't suddenly stop and drop dramatically like it does with women. But if you have prostate cancer, and some men with prostate cancer where we're trying to cure them, we will block testosterone. Like I said, that is one of the main treatments for prostate cancer. But men who have incurable prostate cancer, we also block testosterone. And so pretty much we're taking your testosterone level from here and we're bringing it down. And so just like women who are going through menopause, men can get the hot flashes. You can have trouble with bone loss. It can affect what we call your cardiovascular system and put you at increased risk for heart attacks and strokes. Men with lower testosterone levels may have trouble regulating their blood sugar, and so it's very common if you're on this treatment for a long time. We will monitor your cholesterol, we'll monitor your blood sugar, and sometimes there are strategies to help with the hot flashes. But it can be a big problem in some men. Blocking testosterone can also affect your sexual function. That is quite important for some men.
Okay, I have a question posted here. I'm not sure, since I'm not a doctor, I don't know if this has anything to do with prostate cancer, but
Okay.
Scott is asking us, how important is repairing a hiatal hernia? Is that anything related to prostate cancer?
I would have to say that's something that is not related to prostate cancer.
Okay.
But just to answer a quick question anyway, not all hiatal hernias need to be repaired. And so that's going to depend on how severe it is. You'd have to ask your physician about that.
Okay, great. Now, we talked about potential side effects. How do you know when you do one of these therapies, when say you determine whichever path you're going to take in treating them, how do you tell that it's working? In other words, do they keep getting PSA tests? Do you keep doing, I don't know, x-rays, MRIs, whatever?
Well, by and large, we can follow PSAs. Okay,
Okay.
Most men will have cancers that we can measure a PSA, and if the PSA drops by 50%, that's a pretty good response. If the PSA grows by a certain amount, then that makes us worry that the cancer is growing. However, there are some men who can have, say, a high PSA, and you can do scans and find cancer in the bones, cancer in the liver or lung. There are men who can have a high PSA, and you can do scans and not find anything. And so there is a role for getting imaging sometimes for men with prostate cancer, especially if you're trying to determine, hey, do we need to go through treatment right now? Is it causing trouble? Can we wait on that? Sometimes if you've been on several therapies, we're reluctant to get rid of a treatment if a PSA is going up, especially if we don't find that there's any bone damage somewhere else. But usually if the PSA is going down or if it's stable, that's a great thing. There are rare men who have cancers that stop making the PSA. And when I say rare, I haven't seen it yet, but it's something we always think of, especially if a man has a stable PSA and they're developing new symptoms.
So Scott says thank you.
My pleasure.
Ramona says hello.
Hi, Ramona.
And Barbara says thanks you, doctor, for life-saving information.
Oh, okay.
So are there any new drugs that have come out that you think are showing particular promise in terms of treatment of prostate cancer?
Well, I would say right now We've had a lot of prostate cancer drugs come out on the market several years ago. There's been a little bit of a lull in that. One interesting medication that is not standard therapy for prostate cancer right now, and so whether or not you can get it approved by your insurance is a different question
Right.
altogether. But one interesting class of medications are what we call PARP inhibitors. Okay, and this relates to what we call genomic medicine. As I was saying, you can have a cancer gene that's passed from parent to child that puts you at risk for cancer. And some of those cancer genes, they actually prevent the cell from repairing DNA. And DNA damage can cause cancers, but some of our treatments actually damage DNA and can kill the cancer cell. And so for some cancers, we found that giving PARP inhibitors that prevent the cell from repairing a particular kind of DNA damage can be very, very effective in some people with cancer genes like BRCA1, which we previously just associated with breast or ovarian cancer, but can also be associated with prostate cancer. They've also found that even if you haven't inherited that cancer gene, your cancer, like I said, cancers arise from cells that develop new mutations that you weren't born with. But there are people with prostate cancers who will have mutations in these very same genes, even though it's not in other cells of their body. And these medications might be helpful for those people as well. And so they're studying that. And that is, I think, a field of medicine that I find very exciting.
Also, with prostate cancer, does catching it earlier, you have a better chance of dealing with it than later, just like other cancers?
Well, that's the whole point of screening.
Right.
Okay, so the idea of screening is if you catch something early enough, you can make a difference on curing it. Okay, and indeed, since we started screening for prostate cancer, we found that the death rate from prostate cancer has gone down. The tricky thing, as I said, is it's only gone down modestly, because what is happening is you're diagnosing men who have prostate cancer but would never die from it because it's what we call very slow-growing or indolent thing, a hibernating beast, so to speak.
Right.
And so that's one of the tricky things is we know we are making the difference in some men's lives, but there are a lot of men we are not making that difference and we could be causing harm. They are also using genomic medicine to try to determine which cancers are the bad actors. The problem with prostate cancer is sometimes you can have different prostate cancers staying inside the same prostate. And so one biopsy may not be enough to give you all that information, but they're doing a lot of studies on that right now to see if we can find other ways of sparing some men from over-treatment and then treating the ones that do need it.
Okay, we have a question. Sally is asking, is there a genetic link between prostate and kidney cancer?
Prostate and kidney cancer. Well, the short answer is I'll have to ask my wife. She's a genetic counselor.
Cop out.
So
Cop
I
out. Wait
know
a minute.
I'm copping out on here. But there's new information that comes out all the time. And, of course, the people who are most up to date on that are the people that dedicate their entire lives to that particular field. And my wife is a cancer genetic counselor, and she certainly is one of those. Now, kidney cancer, there are different types of kidney cancer. The most common genetic cause of kidney cancer is called von Hippel-Lindau, which is not something that typically is associated with prostate cancer. It can be associated with some kind of tumors that people develop in the brain and the spinal cord. There are also rare types of kidney cancer, collecting duct cancers, and whatnot, which to the best of my knowledge, are also not associated with prostate cancer. There's a cancer syndrome that's associated with colon cancer that might be associated with cancers that we call the kidney pelvis. But again, that's not something I'm aware of as being associated with prostate cancer. Now, I pretty much gave a long-winded answer for saying no. But I should say one of the things that we are learning is that even though we have a certain cancer gene that tends to be associated with certain cancers, it may not be as clean cut as we had thought in the past. And they may end up finding that some of these genes might give you a modestly increased risk for some other cancers as well, but this is something that's not quite clear at this time.
So what can men do in general to prevent prostate cancer, or any other cancer for that matter, but prostate is the subject of our talk today, so are there things they can do?
As far as lifestyle changes, I would say there is, to the best of my knowledge, not a lot of lifestyle changes that can be done. I mean, we do know that as a general rule, fitness is a good thing, and certain cancers, fitness might reduce your risk for prostate for cancer, but it's not clear to me that prostate cancer is one of them. Losing weight has also been felt to be associated with improving a general cancer risk. There are men who are supplementing, who are taking, I should say, testosterone supplementation to increase sexual function, so they don't lose muscle mass and things like that. And it's not clear if that supplementation is necessary, and there is the concern that taking testosterone supplements could increase your risk for developing prostate cancer. Now, there are medications out there that have been used to try to prevent prostate cancer, and this is something you can always discuss with your primary care physician, or you can even get a referral to a urologist to discuss this further. But these medicines, which also fall in what I would call kind of an anti-androgen-like category, can reduce your risk for prostate cancer. There was some initial concern, it may not be as big of a concern now as we used to think, that it tended to reduce your risk of getting the less aggressive prostate cancers more than the more aggressive prostate cancers. But it's also kind of a complicated subject, but those medicines are available, and I think it's reasonable, particularly if you have a strong family history of prostate cancer, to talk about that with your physician.
Well, we're about to the end of our time here. We've actually gone over a little bit. Is there one last message you have for people who maybe they just got their diagnosis of prostate cancer? What is the thing you want to say to those patients out there who are facing this concern?
I would say, if you've been diagnosed with prostate cancer, all is not lost, okay? It's very important. Men with prostate cancer, even if you cannot cure that prostate cancer, on average, they live years, okay? Now, we'd like to cure it, okay? And if we can cure it, or if it's reasonable to cure it, we'll do it. I think it's important to know that there's time to sort out things, get second opinions if you need to, because again, it tends to be a cancer where you don't have to treat it within the first couple of weeks, and especially if you're not sure that this is an aggressive cancer that needs to be treated, getting that extra information can be very helpful. At NorthBay, we have a relationship with the Mayo Clinic, and we can even send their experts information on our patients who are complicated patients or who have questions about their treatment, so that you can get that kind of built-in second opinion. So
without ever leaving Solano County.
Without leaving Solano County, you don't get charged for your insurance. It's just nice to have that as a backup. There are some people who say you should always get a second opinion for cancer treatment. I don't believe that's necessarily so, especially since sometimes getting those second opinions means trucking out to far distances, and sometimes that leads to a delay in care by months, and that's not something people want to do. But you've got time. When we look at studies treating men with prostate cancer, these studies often have to go on for years because men with prostate cancer do so well. So I just want to let you know there's a lot of hope, and there are treatments in the pipeline, and my hope for all of my patients with prostate cancer is that they can have a normal life and do normal things.
Great. And thank you. Ramona says NorthBay rocks when treating patients for any cancers. And that includes you, Dr. Vikstrom. So thank you very much for doing this. And Tune in a couple more weeks. We'll be doing another Facebook chat with another doctor on another important health issue.
Thank you for inviting me.